Well, hi, I'm Randi Pedersen. I'm with the Idaho Department of Health and Welfare, and I manage the syringe exchange program within the HIV, STD, and hepatitis section at the department. And really, the majority of my career has been spent in infectious disease epidemiology, which is where I really learned about harm reduction. So I'm honored to be part of a growing harm reduction movement in Idaho and look forward to sharing more with you today about harm reduction and pathways to recovery. So first, I just wanted to point out that I don't have any financial or non-financial disclosures. I am an employee of Department of Health and Welfare, and you'll see some photos of specific products throughout the presentation. I just wanted to highlight that I don't favor any specific pharmaceutical, laboratory test, or supplier over another. And again, just highlighting, my expertise is really in public health, and I'm not intending to provide medical advice. I'm just trying to raise up some best practices that are recommended within the public health sphere. So by the end of this presentation, you'll be able to describe the harm reduction philosophy, summarize evidence-based harm reduction strategies to address substance use, have increased awareness of harm reduction strategies being implemented in Idaho, and identify one opportunity to incorporate harm reduction into your work. So first, let's talk a little bit about harm reduction philosophy and strategies. And over the last year, I feel like the general population has started to hear this term harm reduction more and more. So just wanted to point out that harm reduction is just a set of policies or practices that reduce harm associated with the behavior. So for example, some very normalized harm reduction or risk reduction tools that we have include sunscreen, which reduces our risk of skin cancer from sun exposure. Seatbelts and seatbelt laws reduce our risk of death if we're in a motor vehicle accident. So harm reduction is really public health at its core, and it's trying to improve not only individual health, but make an impact on broader community health. So a lot of the work I do is really focused on harm reduction within the substance use realm. So we'll talk a little bit more about that for the rest of the presentation. So when we talk about substance use, we're really talking about people who use drugs. So people who use drugs are a medically and socially vulnerable population who've often experienced some form of trauma. So research suggests that people who use drugs are at higher risk of having experienced childhood trauma, having an untreated mental illness, experienced and survived an overdose, or to have chronic infections like HIV, or more acute infections like hepatitis, soft tissue infections, or endocarditis. And we know that these risks are really often associated with poor healthcare engagement. And there's a variety of reasons for that, but one of the reasons can be stigma. So our literature shows that up to 80% of people who use drugs have experienced stigma when accessing healthcare and other needed health services. So let's break down a little bit further what stigma is and how it affects health. So stigma is simply just a label associated with the negative stereotype. So for example, a label that we hear really commonly, I feel like in the substance use world, is the belief that addiction is a moral failing, instead of what we really know that it is, and science tells us, is that addiction is a chronic treatable disease from which patients can recover and continue to live healthy lives. So stigma comes from our culture. It's really deeply rooted in cultural beliefs, and these are called implicit biases. So there are unconscious attitudes or beliefs that we have towards people that can be positive or negative. And in fact, sometimes those implicit biases are so ingrained, we think that they're normal, and they're what we call our blind spots. We don't even recognize that we have these biases. So it's important to understand our own biases in order to reduce stigma. And trying to contextualize what stigma looks like practically, there's a graphic here from our world in HIV where stigma has been studied most heavily. And the teal circles highlight ways stigma can manifest. So stigma can look like poor access to services or individuals that don't engage with services. It can look like a harassment and abuse, discrimination, which can be both individual or structural discrimination, and it can also look like violence. So stigma can really push people who are not like us to the margins of society, and that marginalization affects our social, emotional well-being, can create economic instability and lead to poverty, and even push us to take on risky situations or behaviors in order to survive, all of which can affect our health. So for these reasons, we know that stigma is what we call a social determinant of health. So how can we address stigma? So first, like I said, we got to understand our own biases that we have and learn to set those aside. And part of the way we can do that is really changing how we talk about substance use. So person first language maintains the integrity of an individual as the whole human being and not equating an illness or behavior with that whole person. So for example, instead of saying that someone is an addict, person first language would say that that person has a substance use disorder. So it has a more neutral tone and distinguishes, like I said, the person from his or her diagnosis. So by simply really changing how we talk about substance use, we can reduce stigma and really start to engage people who use drugs in services. So a great example of how Northern Idaho is trying to change the language we use and reduce stigma is the Call Me Media campaign, which I think you'll hear about too later on today as well. And the Call Me campaign was really led by Panhandle Health and the Region 1 Behavioral Health Board, along with a lot of other community members. And it sought to really name stigmatizing words and language and teach you how to reframe that language in a way that puts the person first. So for example, here, the words associated with this picture say, "Don't call me addict," really highlighting like we're more than our substance use. And instead we want to reframe that term addict to, we are wives, mothers, friends, social workers, students, and a person with substance use disorder. So another way to reduce stigma is by looking at substance use through a harm reduction lens. So there are many definitions of harm reduction when we look at substance use, and I wanted to bring forward this particular definition from SAMHSA. And so if we want to play the video.
Well, for the past 27 years, we have operated what we call harm reduction outreach, and that is our philosophy is simply to assist any positive change as a person defines it for him or herself. So instead of having chaotic, out of control addiction on the one hand and abstinence on the other, and saying these are the only two choices, we've said there's a huge productive middle ground, any positive change and any improvement. So we try to operationalize any positive change. You would define it for yourself, I would define it for myself, and then we as an organization would provide the most cost-effective and scientifically proven means to accomplish those things. But the choice is yours, both to what and intensity. So for almost 40 years, I've been an addictions counselor, and the focus has been on struggling between those two poles, chaotic, out-of-control addiction and abstinence. And the idea was to migrate people who are chaotic and out of control in their drug use to people who are abstinent. That is the traditional model of addiction treatment. Unfortunately, it's inconsistent with human behavior, human condition, and there's a huge fertile field between the two that would be called improvements. In other words, using in a way that does, separating drinking and driving, for example. Hugely successful public health intervention. It's not that we stopped drinking, it's not that we stopped driving, it's that we began to develop mechanisms for separating the two. You see them most on New Year's, things like this where, where there's a designated driver, or cabs or CTA, or the trains are offering free rides and so forth. We realize there's a danger to that, and so we separate the two. It's not that we're prohibiting one or the other. We could, but we don't, because we know it wouldn't work. And that's basically all harm reduction says. is public health is the most important thing. The health of your children, the health of my children, the health of the community, that has to be first. We have to put in the background moralism, condemnation, one's perception of how one should be. And so what we're talking about for the first time is affirming and even rejoicing in improvement, not perfection, improvement. And humans are really good at improvement. We are not so good at perfection.
All right, so I really love that definition and description of harm reduction and substance use, and that phrase of really trying to rejoice in improvement and celebrate any positive change. It's a very strengths-based approach to our work. So to recap, the harm reduction philosophy includes some of these basic tenets, and that it's a very practical approach to address substance use. It's a shift away from abstinence-only recovery. So harm reduction does not condone or enable substance use, but it meets people where they're at. And so what that means is that we really want to understand that people are likely using drugs for a reason. It's a coping tool, maybe to cope with trauma. They're struggling with a mental illness. There are a variety of reasons people use drugs, and our role is really to approach that person with respect, empathy, and without judgment. We have no idea what their journey and their experience has been unless they decide to share some of that with us. And in the meantime, what we want to do is offer services to really build a rapport and connection with folks. And that opens an opportunity for us to be able to use counseling techniques that empower people to make positive changes that reduce harms associated with substance use. So some of those counseling techniques can include things like motivational interviewing or healing center engagement, where we ask people, what's right with you? What are your strengths? And how can we use that to address your substance use and move you forward to achieve your goals? And again, it's really individualized in how those harm reduction conversations are approached, because it's really up to the person to choose what positive change looks like to them. So maybe that is simply coming in for certain services. Maybe it's choosing to use in a safer manner or manage their use, reduce their drug use, or it can even include abstinence from drug use. So research has really demonstrated that building this sense of power and control among traumatized groups is one of the most significant features in being able to restore their holistic well-being and get them to recovery. So for people who use drugs, obviously it's best for them to stop using altogether. That's really hard and not necessarily practical for most people. So for people who are not ready to stop using drugs, there are a number of harm reduction strategies in combination with the harm reduction philosophy that we can use to meet people where they're at, encourage that positive change, which can be, like I said, safer drug use or a reduction in drug use. So some of those harm reduction strategies that we use to address substance use include housing first programs that don't require sobriety for individuals to be housed, overdose prevention and response efforts, syringe service programs, which formerly have been called syringe exchanges. But that term has really been reframed in the last couple of years to highlight that safer syringe programs or syringe service programs really do more than just needle exchange. They provide comprehensive services to people that use drugs. Also healthcare services like infectious disease testing, wound care, medication for opioid use disorder, those all fit under the harm reduction umbrella. And behavioral health services like counseling, recovery coaching, and even peer supports. So it's important to note that a lot of times, of course, people who use drugs are going to benefit from a combination of these different harm reduction strategies. And the rest of the presentation will really focus on 3 of these strategies that you may be less familiar with. And we'll talk a little bit about the evidence base behind those and how they're being implemented here in Idaho. So before we look to the evidence around harm reduction strategies, I just wanted to highlight that Harm reduction work is really most effective when done in collaboration with multiple disciplines. We all have a role to play in serving people who use drugs, from behavioral health to public health, social service providers, our pharmacists, healthcare providers. And at the heart of this work are really people who use drugs, their family and friends. A lot of these strategies were developed by people who use drugs for their peers. And in public health, in the prevention world in particular, we have a saying, nothing about us without us, just really highlighting the importance of continuing to remind ourselves and incorporate the lived experience of people who are using drugs and their family members and friends into the work we do at the state and local level. So now let's dive more into the harm reduction evidence base. The first harm reduction strategy that we'll examine more closely is called Housing First. So among people experiencing chronic homelessness, up to 78% have a substance use disorder. So Housing First is a model to rapidly end homelessness and addresses some of the underlying causes of homelessness. So research shows that this model is particularly effective among people who have mental health conditions or substance use disorders. So the picture on the right shows the traditional model for housing readiness that requires an individual to access emergency shelters. And through the shelter, they can gain access to additional medical and behavioral health services. A lot of times for people that have a substance use disorder, in order to access transitional housing, a lot of times that's safe and sober housing, or there's a requirement for folks to be abstinent from substance use, especially to be eligible for permanent housing. And the research really shows that this housing readiness model is really hard for people with substance use disorder to achieve. So in fact, only about 40% are successful in stabilizing their substance use in order to access transitional and permanent housing. So instead, the Housing First model is a harm reduction strategy that incorporates ideas rooted in Maslow's hierarchy of needs, which is the figure on the left. So Housing First prioritizes the lower levels of Maslow's hierarchy, really addressing physical needs in orange and safety needs in kind of the lighter orange over abstinence from substance use. And they do this by providing permanent, stable housing without requiring sobriety. So if we go back to the figure on the right, the bottom portion there describes the Housing First model, where we rapidly house someone in permanent housing. And in that housing, we embed wraparound services that address the underlying causes of homelessness. So once people are stably housed, we find that they're better able to take advantage of those services, and they're able to maintain housing stability, employment, and start to access recovery. So the literature really shows that this Housing First model is much more effective in reducing homelessness. So instead of 40% of people being successful, now 60 to 80% of people are successful in staying off the street and staying housed. So we also see too that these models are incredibly cost effective. Individuals who are experiencing chronic homelessness due to a mental health issue or substance use put a tremendous strain on our emergency response and criminal justice systems. And so when they're stably housed with wraparound services, addressing those underlying causes for homelessness, we see a dramatic decline in the number of ER visits, crisis center visits and interventions, and arrests. Residents also report positive impacts on their quality of life and community functioning. And there is limited data on the long-term physical health outcomes and even impacts on substance use among Housing First residents. But there is a recent study out of New York that demonstrated that there is a reduction in their Housing First participants, a reduction in the consumption of alcohol, stimulants, and opioids. So for some people, really their goal might not be directly related to substance use. Maybe their goal is permanent, stable housing. And that's a positive change that reduces their harms, keeps them safe, and honestly improves their chance of survival. So the next strategy we'll examine is overdose prevention and response. The number one priority with this strategy is to keep people alive and as healthy as possible so that they have an opportunity to recover. So when we talk about overdose prevention and response, we really have to address how Idaho's drug supply has fundamentally changed in the last few years. So we're seeing more and more powerful synthetic opioids like illicitly manufactured fentanyl and fentanyl analogs in Idaho's illicit drug supply. Now, sometimes fentanyl is pressed into pills to look like legitimate prescription opioids. And we're also seeing fentanyl in heroin supplies and even stimulants like methamphetamine and cocaine. So illicit fentanyl really is the primary driver of Idaho's drug-related overdose deaths that continue to rise over the last couple of years. Preliminary data from 2021 shows that at least 318 Idahoans died from a drug-related overdose, which is a new record high for us, unfortunately. And at least half of those overdose deaths involved fentanyl, which is nearly double the proportion from the year before. So why is fentanyl so deadly? Not only is it more potent than heroin or prescription opioids, but it's interesting. I've heard a couple colleagues who work very closely with people who use drugs. They talk about these fentanyl overdoses that really have a rapid onset of respiratory suppression, like within seconds. People will consume a substance and stop breathing. And so unless someone is there to respond, really the risk of that person dying is imminent. So national data from CDC suggests that over 65% of drug overdose deaths had at least one potential touch point to prevent overdose or prevent a fatal overdose. So in almost half of fatal overdoses, a bystander was present, so either a friend or a family member. So and if that bystander is present and armed with naloxone, they can effectively reverse an overdose and save that individual's life. So naloxone is a medication that's also called an opioid antagonist. It can quickly and safely restore normal breathing that has been suppressed when someone overdoses and save the life of that person. One of the strategies we use is called targeted naloxone distribution. And what that means is that we want to get naloxone kits into the hands of people that can respond to these overdoses. So people who are using drugs, their friends, family members, and first responders. So an individual armed with naloxone can easily administer it either by squirting a nasal spray up the nose of the individual that's overdosing. And that product is typically, the brand name is typically known as Narcan, or you can also give naloxone as an injectable medication as well. So the evidence base around targeted naloxone distribution, there's a couple different pieces. So we know from a policy perspective, there was a large scale national study that showed opioid overdose deaths decreased by about 14% in states that enacted naloxone access laws. So naloxone access laws are really laws that loosen traditional restrictions around prescribing, dispensing, and administering naloxone. And I think a lot of states have taken this approach, including Idaho, because we know that naloxone is a drug that poses no risk of abuse. It doesn't generate physical dependency, and it really poses negligible risk of harm if it's given to someone who's not experiencing an overdose. So we feel like it's a very safe drug, and in order to respond to this massive overdose epidemic we're experiencing, we realize that we need to lower the barriers and get it out to people that need it. So we can do that through policy. Another opportunity too is to distribute more and more naloxone to the community to reach what we call naloxone saturation is the new term we're using. So, and statistical modeling shows us that high rates of naloxone distribution to people that are able to respond, so people that are using drugs together or first responders, could avert up to 21% of opioid overdose deaths. And we also know too from a number of national studies and state studies that 80 to 90% of overdose reversals are actually done by people who use drugs that are with the person that's overdosing. So we know that that is one of the most important groups for us to target for naloxone distribution. So there are other overdose prevention and response strategies beyond naloxone that are emerging as promising harm reduction tools that I just wanted to touch on briefly. One of those strategies is never using alone. Using substances alone is the leading risk factor for fatal drug overdose. And there are a number of reasons that we know people may use alone. People report it's convenient, it's comfortable for them. They're concerned about the stigma associated with substance use, and so they hide that behavior. They do it for safety reasons, and they may simply not have a friend that can be with them in that moment while they're using substances. So we know, like I said, naloxone is a very effective intervention, but you have to have somebody present to administer it. So there's practical messages that we've come up with to really encourage people who use drugs to, stick with who they trust, have a plan, and avoid using alone if possible. So if that's not an option, we could definitely encourage folks to call the Never Use Alone hotline. They have personnel on the other end of the phone that will get your location and call EMS if you do not respond within a certain amount of time. There really is very little research to date that supports the efficacy of these messages or interventions to reduce overdose rates. We do know, however, conversely, that one of the best ways we can prevent fatal overdose is providing safe consumption spaces. Safe consumption spaces are spaces where people can go in and safely use substances, and then they're monitored by medical professionals. So it's a really well-studied way to ensure that people are not using alone and dramatically reduces people's risk of overdose. So this model is really well-known and well-researched in Canada. It's being piloted right now in New York City. It has not really been well accepted in the US yet. So another tool we have are drug testing technologies such as fentanyl test strips. So this is a picture of what fentanyl test strips look like. They're a little piece of paper that really uses the same technology as at-home pregnancy tests. So it was originally developed to detect the presence of fentanyl in urine, and it's FDA approved for that. But fentanyl test strips are now being used off-label as a harm reduction tool by people who use drugs. So these test strips are really cheap. They're less than $1 a strip. They're very accurate, 96 to 100% accuracy in detecting fentanyl and its analogs, and they're really easy to use. So there have been a few studies looking at the impact fentanyl test strips may have on behaviors of people that are using drugs. And one study that's, I think, the most well-known is the Forecast study from Johns Hopkins that was done in 2018. It compared 3 different drug checking technologies and found that fentanyl test strips are a low-cost and relatively accurate tool that people who use drugs liked using. And they surveyed people that were part of this study, and 86% said that they would use a fentanyl test strip to test their substances before consumption. They were really concerned about fentanyl being in the drug supply and knew the risk that it carried and the likelihood that they could very quickly overdose. And 70% report that they would take the results from the fentanyl test strips and use that to change their behavior. So they might use less of that substance. They might make sure that they have naloxone on hand, for example, or they might choose not to use that particular batch of drugs at all. So really more research is needed, but these early studies suggest that drug checking by and for people who use drugs may be a good addition to our current evidence-based overdose prevention and harm reduction strategies. The third strategy we'll look at today are safer syringe programs. So safer syringe programs are community-based prevention programs that offer a range of low-barrier harm reduction services to individuals who use drugs. So some of the services they offer include safe syringe disposal. And this really prevents needle stick injury, well, improper disposal of used syringes in maybe the community or public spaces, and can reduce needle stick injury to community members or public safety workers, including law enforcement officers. The data shows that 1 in 3 law enforcement officers are likely to experience a needle stick injury in their career. And that can happen when they're patting down a suspect or, going through a car maybe, and they inadvertently stick their hand in a crack of a seat that has a used needle in it. And so by providing opportunities for people to safely dispose of their syringes, it can reduce the likelihood that they're going to be carrying things around and reusing it. Another service that syringe service programs provide are access to sterile syringes and other safer use supplies. And access to sterile syringes is one of the best ways we have to prevent the spread of infections such as HIV and hepatitis C that people can spread when sharing used syringes. So it dramatically reduces this needle sharing behavior if you have access to clean supplies every time. Syringe exchanges also not only provide naloxone to people that are using drugs, they teach people who inject drugs, in particular, how to prevent overdose and how to respond in the event that a friend overdoses. And lastly, exchanges provide connection to services such as health exams, substance use disorder treatment, mental health support, and when people are ready, access to recovery. So these are one of the most heavily studied interventions in the harm reduction world. And I think that that's because it seems counterintuitive that these programs would be effective, but they are. There's a very strong evidence base for SSPs, and that base is so strong that numerous health organizations have put out statements of support for these types of programs, including the World Health Organization, American Medical Association, and syringe service programs and harm reduction is part of a new Health and Human Services 5-point strategy to combat the opioid crisis. So what is the evidence? So we have 30 years of research that shows that syringe service programs reduce overdose deaths. They're also associated with approximately 50% reduction in HIV and hepatitis C incidence. And when we combine access to syringe service programs with medication for opioid use disorder, we see that HIV and hepatitis C transmission is actually reduced by more than 2/3. And the reason being is that we're providing access to sterile supplies, and we're really changing that needle sharing behavior. So people who use SSPs also show a high readiness to reduce or stop their drug use. And I think that's why you see that they're 3 times more likely to reduce or discontinue injection drug use and 5 times more likely to enter treatment for a substance use disorder. The beautiful thing about syringe service programs is that they are providing a connection for people that are using drugs and marginalized in our society. And then through developing that connection and trust with a provider, they're starting to access these additional wraparound services to address their substance use and reduce harms. So research also shows that syringe service programs reduce syringe litter in the community and do not increase crime. So now that we've talked a little bit about the harm reduction philosophy, the evidence base behind some of the strategies that we use in harm reduction, let's talk about how those strategies are being implemented in Idaho. So New Path Community Housing is Idaho's first Housing First program. It's based in Boise, and there's a photo of it there on the right. And it's based in Boise, where Idaho's largest population of individuals that are experiencing homelessness typically congregate. So the approach at New Path is really to provide low barrier access to permanent housing with on-site wraparound services. So most of the residents at New Path have a chronic or debilitating health condition, such as a mental or brain disorder, long-term addiction to drugs or alcohol, or have experienced trauma. So the on-site services are provided by Terry Riley Health Services, and those include things like case management, physical and mental health care, substance use counseling, life skills training, and peer support groups. They also provide assistance with helping residents obtain Social Security and other government benefits. So after living at New Path for a year, residents who wish to move to another housing option are eligible for a tenant-based voucher. So an evaluation was performed by the Idaho Policy Institute in 2019 and 2020. And they were able to demonstrate a 60% reduction in the use of emergency services by residents at New Path, simply by being housed. They also were able to demonstrate a reduction in substance use and mental health crisis treatment once people were stably housed. And I think that was well shown in this graph here on the right. The orange and blue bars on the graph represent both substance use and mental health crisis care and the number of days that they were in those or accessed those services. And the vertical line, the orange vertical line here at month 0 is when an individual was housed at New Path. So you'll notice there's a lot of bars before somebody was housed. And then after that orange line, the number of bars reduced dramatically. So what we're really seeing is a large reduction in the use of substance use and mental health crisis care among those that remain stably housed. So there are some orange bars to the right of that orange line. And those are folks that chose not to remain in New Path and went back to being unstably housed. And they returned to their previous pattern of seeking crisis and substance use emergency services. New Path also has some pretty amazing cost savings to the community. It's estimated that this program has saved the county $2.6 million simply by reducing all of those emergency services that were typically being provided to this population. They also too have really high retention rates. Up to 80% of their residents remained housed after 2 years. So incredibly successful. And as a result, a second housing first unit has been opened specifically for veterans in the Boise area called Valor Point. So how might you incorporate this strategy into the work that you're doing? The really neat thing about this particular example is that it was really a community-led effort to address homelessness and the underlying causes of homelessness. And so I would say, like, if you see a need for this type of intervention or strategy in your community, start by talking to your community leaders about this housing first idea. And let us know if we can help connect you to experts that are operating this program in Boise or other parts of the country. So another strategy that's working in Idaho is targeted naloxone distribution. So Department of Health and Welfare brings together a number of different federal funding sources to support naloxone distribution to organizations through our mini grant program. We really target organizations that work directly with people that use drugs and also first responders. So we have a subgrant in place with Idaho Harm Reduction Project, which is a Boise-based syringe service program, and they manage all of our naloxone distribution for us across the state. So that really has enabled us to hire the experts to do this work. And we have been able to centralize our prescribing using a standing order from their medical director, ordering and distribution of naloxone to organizations. So we combine naloxone distribution with training and technical assistance from health educators at each of Idaho's 7 public health departments, and including your local health department, Panhandle Health. And our 2021 outcomes, we distributed almost 9,000 naloxone kits to organizations in 41 of Idaho's counties, so almost all of Idaho counties. And this photo is an example of the overdose rescue kit that you can get from the mini grant program. The top 3 organizations that are receiving naloxone are law enforcement, substance use treatment providers, and syringe service programs. And over 300 overdose reversals have been reported by mini grantees in 2021. Interestingly, in 2022, we've almost doubled the amount of naloxone that we've distributed to organizations across the state. So how can you incorporate this strategy into the work that you're doing? Well, for organizations, definitely would encourage you to look into carrying or distributing naloxone. So you can find some example policies and request naloxone through this mini grant program from DHW using this link here. And you can get training from your local health department, such as Panhandle Health. For prescribers, it's important to talk to your patients about substance use. You can also certainly use resources like the Idaho Prescription Drug Monitoring Program called AWARE, there's a link here to see if your patient has been prescribed an opioid and maybe they need a prescription for naloxone as well. And of course, when prescribing opioids, it's best practice to always co-prescribe naloxone. For patients in family of people who are using drugs, carry naloxone on you. You can find naloxone at findidahotesting.com or through Panhandle Health's resource map. And then also too, if you're prescribed an opioid, it's important to safely store and dispose of that medication using some of the tips that are provided through this link here. So this sticker is, again, a really great resource that was developed by Panhandle Health from a campaign called Not Scary to Carry. It's a naloxone campaign that really aims to normalize carrying naloxone and increase naloxone saturation in the community. These stickers can certainly be placed in community locations. I've also seen two window clings, for example, in like some of the shelters in Boise here in particular, have a window cling that says, naloxone is available here if there happens to be an overdose event. We do get a lot of questions about who can carry and administer naloxone, about liability and the law, and I certainly would be happy to answer some of those questions in the Q&A, but there's also a frequently asked question resource that we developed that can be accessed here as well. So safer syringe programs were authorized in Idaho in 2019 through the Syringe and Needle Exchange Act. And this is kind of my bread and butter. It really provided a new opportunity for us to engage people who are using drugs and address substance use in a way that we haven't before. So my role at Department of Health and Welfare is to provide operational guidance and capacity building support to organizations that are interested in operating a syringe service program. So we now have 8 exchanges across syringe service programs across the state, 3 of which are serving North Idaho. Those include North Idaho AIDS Coalition, or NIAC, that's based in Coeur d'Alene, Latah Recovery Center in Moscow, and First Steps for Life Recovery in Lewiston. The largest syringe service program in North Idaho is really North Idaho AIDS Coalition. And on the right here is a picture of Teresa, who is their executive director at NIAC, and she is out with their mobile unit talking a little bit about the services they provide. They not only provide services through their mobile unit, but they have a fixed location in Coeur d'Alene. And some of their services include, of course, like Safe Sharps disposal, but they also operate a found syringe hotline, provide access to naloxone, HIV and Hep C testing, variety of harm reduction supplies, hygiene kits, wound care kits. They offer support groups. They have a social worker who can support social service needs. And then they have really great partnerships with some of you that are probably in this room, including like Heritage Health Street Medicine for additional healthcare needs that folks might have, and some of our recovery partners like Kootenai Recovery and Ideal Option and other organizations that offer behavioral health and recovery support services. So annually, Department of Health and Welfare conducts a survey to measure outcomes at Idaho syringe service programs. And we just wrapped up our 2021 annual survey. So this is data from last year. And we see that Idaho's syringe service programs served almost 1,000 participants from all areas of the state. So the map on the right, any of the counties that are colored in green had at least one individual, one resident that participated in services from a syringe service program. So I think it just really points to how widespread substance use is. It's everywhere, it's in every community, and how much there is a need for these types of services. So Idaho syringe service programs really save lives. We see by far the most overdose reversals reported through our syringe service programs. And in 2021, there were 628 overdose reversals reported by syringe service program participants that were getting naloxone from the exchange. We also see too that the spread of infections are reduced. And so we tried to do some internal modeling to look at what that actually would look like in the community. So we took into account in our model things like syringe coverage rates, infectious disease rates, screening rates through syringe service programs for different infectious conditions. And we tried to estimate the number of infections that were averted by people accessing syringe services. So we estimated that simply accessing syringe service programs and using sterile syringes to inject drugs. So we see that an estimated 116 hepatitis C and 35 HIV infections are averted among syringe service program participants. And this is estimated to save the state up to $22 million in associated healthcare costs if these infections actually happened. Another exciting piece I think we see is that syringe service programs are really a pathway to recovery for a lot of Idahoans. We had 915 recovery referrals requested in 2021, demonstrating that these folks really may be ready for change and ready to access recovery, and at the very least wanted to learn a little bit more about what that might look like for them. So Idaho is also exploring some innovative syringe service program models to reach people who use drugs and provide harm reduction services to them. Harm reduction vending machines are an evidence-based model that's used in Europe, Australia, and more recently by some of our colleagues in Nevada. It operates like a coin-operated soda vending machine, but instead participants use a unique code to access harm reduction supplies that are dispensed by the machine. So research really shows that this model is great at engaging young substance users who are not already using a syringe service program. It also increases community access to sterile syringes and reduces that needle sharing behavior amongst folks. So in Idaho, we see about 20% of the estimated 4,800 people who inject drugs at our syringe service programs. So we know that there's another 80% of folks out there that could benefit from harm reduction services that we're not engaging. So we wanted to pilot this particular model. And this project was funded by SAMHSA, partially funded by SAMHSA. And our approach really was to host some community stakeholder meetings, review the literature, and together as a team, we developed a plan to implement this harm reduction vending machine pilot program. So the machine is actually owned by Idaho Harm Reduction Project, and they will manage the vending machine network if we choose to expand this particular model. And they stock the machine with all the harm reduction supplies that you would find at a typical syringe service program. So there's things like naloxone in there, which is one of our most popular items, by the way. Sharps containers, pregnancy tests, HIV home test kits, which is also a very popular item. Safer injection supplies, sterile syringes, and many other items too. So the machine is hosted by an opioid treatment program called Behavioral Health Group, which is located here in Boise. They have a number of locations across the country, and they also host a machine in Las Vegas, Nevada. So they were a great partner that was very familiar with this model, and I think helped guide us a lot in how to implement it. So we also paired the vending machine with a recovery coach. And so the idea again is to have this recovery coach really build connection and rapport with participants that were coming in to use the vending machine and start a conversation about other services they might need and engage them in recovery when they're ready. So we implemented this vending machine pilot in July of 2021, and we're wrapping up the evaluation now. It's been about a year. Our preliminary outcomes from July to December of 2021 showed that we had about about 30 participants. Over half of the participants met with a recovery coach for the first time. 10% actually initiated medication for opioid use disorder at behavioral health group. 88 overdose reversals were reported, which is a huge number to me for like the small number of participants. And what we hear from our colleagues that host the vending machine is that a lot of people that access the machine are getting naloxone for their friends and family that they know are still using. And then 1 in 4 got a home HIV test and now know their HIV status. Okay, so how might you incorporate this strategy of, connecting folks to syringe service programs as a harm reduction strategy? So for organizations, I would definitely encourage you to visit your local syringe service program, build a relationship, and refer clients there that could benefit from that service. This picture on the right is of Idaho Harm Reduction Project's office. These aren't scary programs. They're just like any other service program or clinic. And they just provide, really specific services to a marginalized population. Another opportunity can be to provide harm reduction supplies directly to your patients or people that you serve through your organization. So we do have organizations across the state that have naloxone on hand, organizations that carry what we call weekend kits. If someone wants to access recovery, but it's a weekend and they aren't able to get in to see a provider and start MOUD until Monday, we can give them a weekend kit, get them through the weekend safely if they need to use, which they probably will. And then on Monday, they're ready to show up for that appointment, get started on MOUD, and get connected with other services. For patients and family, you can find a syringe service program at findidahotesting.com. And I just wanted to highlight too, anyone can access harm reduction supplies through a syringe service program. So a lot of these programs do outreach in the community and provide things like I said, hygiene kits to people that are unstably housed. They partner with reentry programs to provide backpacks for people. They also are serving some of our friends that are transitioning maybe from male to female and need to inject different hormones. And it's hard to find some of those specialized needles and syringes to inject hormones. And so can certainly be seen to at a syringe service program to obtain access to some of those resources that are hard to find. All right, so some key takeaways and lessons. I just want to say for people who are using drugs, obviously it's best to stop using altogether, but being pragmatic, we know that there are people that are just not ready to stop using or, it's hard, it's complicated. And so what we can do is really engage them by using person-first language and bringing a harm reduction lens to our work. So there are a number of strategies that we can use to meet people where they are, encourage positive change and reduce harms associated with substance use. And those strategies are really rooted in the evidence. We know that these strategies save lives, reduce the spread of infections, reduce substance use, and can be a pathway to recovery. So the harm reduction movement, as we call it, is really gaining a lot of traction in Idaho, thanks to the work of our community-based organizations that are implementing these programs like North Idaho AIDS Coalition, and thanks to people who use drugs that care about each other and are also implementing these programs in their community. So I really hope this presentation has inspired you to consider harm reduction as another path to recovery and maybe incorporate harm reduction philosophy and strategies into your work. If you want to learn more, you certainly can request training from us. Department of Health and Welfare provides harm reduction capacity building training through 2 of our contractors, Idaho Harm Reduction Project, and another syringe service program out of Montana called Open Aid Alliance. And lastly, there's my contact information. Thank you so much, and I look forward to hearing your questions.